So today we will be discussing about abdominal examination, especially about the abdomen masses. Okay, and the abdomen is called the Pandora's box in clinical examination, mainly because the clinical symptoms may not always correlate with your final diagnosis, especially the pain symptoms. Okay, the pain symptoms does not correlate with the organ which is underlying there, mainly because there is a difference between the visceral pain and the sensory pain which you feel, somatic pain and the sensory pain. Okay, so the abdomen, most of the abdominal pains and the organs pain will be visceral pains. Okay, so it will not be very localized, it will be diffuse pain, and there will be associated nausea and other conditions which are associated with it. So because of that difference, it is not localizing, and the pain, sometimes the pain which is there in the right hypochondrium or right iliac fossa may be because of even a gastric perforation, that is an organ which is in the epigastric. Okay, so the pain does not correlate with the underlying organs. So if you can palpate and mass there, then that may correlate with the pathology, but pain as such is very misleading. Okay, so we will discuss with the abdomen examination, as we have the abdomen examination, as we already discussed. It is very tricky, and yeah, in the differential diagnosis, the diagnosis may be very different than what you expect there. So always do a thorough head to toe examination, and when you're doing an abdominal examination, always expose the inguinal areas as well as the external genitalia, mainly because the external genitalia, the testicular tumors, as well as the hernias may present as abdominal symptoms. Okay, so if there is a strangulated hernia or an obstructed hernia, the patient may present with abdomen distension, vomiting, and pain in the abdomen also. Also, the testicular tumors usually metastasize into the para-aortic lymph nodes. So again, there may be a swelling in the testis which you may miss, and which is presenting as a epigastric mass, and you may think that is because of the pathology of the pancreas. It may not be. Okay, so always do a thorough head to toe examination, as well as expose from the xiphisternum to the external genitalia. Okay, always expose the patient there, and then you have to examine the patient. Initially, we will discuss about symptoms which are present. Then we will go to the examination part. Okay, so in the next examination, the examination will be performed in this. Okay, we are not. Okay, there is no slide about clinical anyway. But so the symptoms, there are not much. The clinical symptoms, there is no. We are not discussing much. Also, because only 1 hour time is there, so I are not prepared slides. Always ask the patient what the symptoms are. Most of the times, if the patient has an abdominal pathology, he will present with abdominal pain. As I already told, abdominal pain, the site of abdominal pain may be very deceptive. Okay, it may not be just the pain, where the patient says he has pain may not be the organ which is involved. Okay, so that is very deceptive. Then the patient may have vomiting. Okay, and as well as abdomen distension may be there. And upper and lower GI bleed may be there. The patient may have hematemesis because of the upper GI bleed, or the patient may have melena, or the altered blood, that is passing altered blood in the stools is called melena. So the patient may have melena, or the patient may have hematochezia, that is passing of fresh blood in the stools. Okay, all these things have multiple differential diagnosis. Okay, as well as some of those symptoms, for example, diffuse pain all over the abdomen, as well as vomiting and abdomen distension, may be non-specific. It may be seen in multiple diseases. So it's always important to do an abdomen examination and look for signs which you can localize the pathology. Okay, and because it is so difficult to diagnose an abdomen pathology, most of the time we rely on USGs as well as CTs. Okay, if the patient has severe abdomen pain and you're suspecting an acute abdomen, most of the time we will end up with getting a CT, and proceeding as the CT says. But still, it's an art which you have to still know. No? It's an art and a science, the examination of the abdomen, which you have to still know. Maybe in your practice you may not follow it, because as I told, it does not always correlate with the end pathology. Okay. Still, if some masses are palpable, then you can correlate the pathology, and that is what we will be discussing, the abdomen masses. Okay. Next, the abdomen wall description. There is for abdominal examination, the abdomen is divided into four quadrants. Initially, when you're taking history, you can use the four quadrants of the upper right or left upper, right upper, right lower, and left lower. You can just tell those things mainly because even the patient will tell you in the same vague terms, isn't it, in your history? So you can use these terms in your history if you want. Okay, that is, the patient says he has pain over the right upper quadrant of the abdomen, or right upper side of the abdomen. You can say that. You can use that in your history taking. But in your examination, always you have to use the 9 quadrants of the abdomen. You have to divide it into 9 quadrants and use it in your examination when you are explaining to the examiner. Okay, so the abdomen is divided into the 9 quadrants by the prepyloric line. This is the prepyloric line, and transtubercular line. Okay, so we will discuss again what all those things are. So it is divided into 9 quadrants. Okay, right hypochondrium, epigastrium, left hypochondrium, left flank. Okay, left flank, umbilical, right flank. You can even flanks are also called. Left flank is a normal general term. So here we use left lumbar, okay, right lumbar, okay, right iliac, left iliac, and hypogastrium are the suprapubic. So how will you go with the abdominal examination? The abdominal examination, we do the general appearance of the abdomen first, okay. In your Then you go for inspection and palpation, percussion, and then auscultation. Okay, it should include the examination of inguinal areas, which we already discussed, a rectal examination and pelvic examination, mainly because even these things can present the pelvic. These ovarian masses are the mass from the uterus may also present as lower abdominal mass. Okay, so always do, if you are suspecting, if the patient has a pelvic mass, if you are suspecting a pelvic mass, always do a pelvic examination of the patient. But that may not be required in all patients, but rectal examination, okay, the patient if presents with abdominal symptoms, always do a rectal examination. That is, especially if the patient has altered bowel habits. Okay, so the patient has constipation, or the patient is telling that he has diarrhea or spuria, that is mucus in stools, all those things, always do a rectal examination. Okay, so these two things are important. Okay, that you have to do in an inguinal area, you have to expose the inguinal area, as I already told. You always expose the inguinal areas as well as the external genitalia. Okay, then a rectal examination. Even if you don't do a rectal examination, always in your history taking, always tell that rectal examination was not done. We couldn't do the rectal examination, but you have to tell that the rectal examination should be done. Okay, so one of the how will you do here? Hmm. So we will be discussing abdomen masses in this classes. Okay, so what are the differential diagnosis of abdomen masses? Okay, and when we discuss about the specific abdomen mass, we will discuss about small details about the clinical history also, how the patient will present to you clinically. Okay, but once you're going to examine the abdomen, it will be first will be the inspection. So what all will you look? You will look at the distension of the abdomen. Okay, if there is any irregular mass, okay, how is the mass, all the quadrants, if all the 9 quadrants are symmetrical, that is what you're going to look. Okay, or if all the 4 quadrants, if we showed right upper, right lower, okay, and left upper and left lower, if all the 4 quadrants are symmetrical, there is no increase in one side of the increase in the size of one side of the abdomen, that you have to look for. Okay, that is irregular. Okay, that is what is calling as irregular. Okay, and distended and scaphoid. Okay, if there is any abdomen distension. Okay, what's the general shape of the abdomen? Okay, and then here other thing you have to look for is the umbilicus. Okay, umbilicus. This is the abdomen. This is the umbilicus. Okay, so you look at the umbilicus also. Is it deviated? If the umbilicus is central or if it is deviated, and what is the shape of the umbilicus? Usually, in a patient with abdomen masses, or if there is any abdomen distension, if any mass is occupying the abdomen, or if there is any fluid occupying the abdomen, that is called ascites. then the umbilicus will be everted. Okay, it will be protruding out. Okay, it will be protruding out. So if a patient presents to you with an umbilical hernia, okay, in an old age, sudden onset of umbilical hernia is there. Sometimes it may be because of old age, but always get a USG to rule out any abdomen, some occupying space, occupying lesion inside the abdomen, which is causing protrusion of the umbilicus. Okay. Also, if a patient is obese, if the patient is obese and the abdomen distension is because of the obesity, the umbilicus will not be everted. It will be a deep umbilicus. Okay, deep well like umbilicus will be there. It will be inverted for this thing like this. Okay, if the this is the abdomen wall, this is the umbilicus. Okay, it will be very deep umbilicus. If the patient has an ascites or some abdomen this thing is there, it will be everted like that. Okay, so it will be protruding. It will be everted like that, the umbilicus. So look, you have to look at the umbilicus. That is a very good important sign. And then you have to look at the flanks. Okay, flanks is these sides, these both sides which are there. That is the flanks. This both and this here is the flank of the abdomen. I'll show you picture how it will look in ascites. If flanks are full, what is it with this thing? Okay, so all those things you have to look for. And these are some of the examinations and some of the term for general distension of the abdomen. Okay, for a patient there is no mass as such, but all of the abdomen is distended. It is usually seen in ascites or abdomen obstruction, it is intestinal obstructions. Okay, and if there is some ascites or obesity. Okay, all these things will lead to general distension of the abdomen. Okay, and next things we look at is the in skin. We will look out for ecchymosis around the umbilicus. That is, ecchymosis around the umbilicus or in the flanks. This is usually seen in hemorrhagic retroperitoneum. Okay, so if there is some hemorrhage in the retroperitoneum, then this occurs. And the most common cause of hemorrhage in the retroperitoneum is hemorrhagic pancreatitis. Okay, hemorrhagic severe pancreatitis. Okay, the pancreatitis is so severe that it is even it is causing damage to the vessels which are there in the posterior. Okay, retroperitoneum. So it causes bleed in the retroperitoneum, which will track into the umbilicus as well as in the flanks. Okay, it is called Cullen's sign. Okay, if there is any umbilical and flank ecchymosis is there, it is usually seen in pancreatitis. Okay, and the other thing it can happen is in trauma. As I told, that is that those signs are mainly because of hemorrhagic retroperitoneum, that is bleed in the retroperitoneum. So that can happen even in trauma. Okay. So we will go to the palpation. As we are discussing the masses, we will jump forward into the palpation. The history taking, as in abdomen examination and history taking, I hope you know. We will discuss in a small part of the history taking, but detailed history taking, I hope you have. The class has been taken in third sem. Okay, as for your final years, I don't think you need those things. Okay, need me to explain those things now, as also the time is less, so we will directly jump into the palpation of the abdominal masses. Okay, so palpate, you have to palpate each region. If, for example, if the patient has pain anywhere, always keep away from the pain when you are palpating. For example, if the patient is suspecting an appendicitis, okay, a patient has pain in the right iliac fossa. If the patient has pain in the right iliac fossa, always palpate the other part and usually restrict the right iliac fossa to the last. Okay, wherever the patient tells that he has severe pain, always make it a point that you examine it at last. Mainly because the patient will get apprehensive. If you go and palpate the right iliac fossa, if you're causing pain, the patient will get apprehensive and he may not be cooperative, or there may be non-voluntary contraction of the muscles of the. There may be involuntary guarding of the abdominal muscles also, and the patient also may not be cooperative, and if you cause pain in the initial stage itself. So always palpate the site of the pain at last. Okay. So that is what we mean by here. Work towards the area of pain. Don't palpate wherever the patient says he has pain in the first part. Okay, always in next, and then warm hands. These are not very important in a tropical country like India, but still, if you suspect, if you are somewhere in North India, Delhi or somewhere, and it is winter, always make sure that your hands are warm. Okay. Uh, Here in Kerala, I don't think that's a problem. always communicate with the patient what you are going to do. Okay, before examining, tell the patient what you are going to do, and then you can do. Okay, and relax the abdominal muscles. If you want to palpate the abdominal muscles, or if any some mass is there you want to palpate, always place the patient supine and knee should be bent. So that knee should be bent so that the abdominal muscles are relaxed. Okay, and ask the patient to relax the abdomen. Okay, sometimes the patient may be apprehensive and there may be involuntary guarding may be there. So ask the patient to relax his abdomen. Okay, and place the knee in a bent position. Okay, so that the abdominal muscles are relaxed. Okay. So these are the quadrants of the abdomen. That is right upper quadrant. That is the right upper quadrant is the right hypochondrium. Left upper quadrant is the left hypochondrium. Okay. Right flank, or as we already discussed, it can be called lumbar also. Okay. Lumbar, left flank. So what are the organs which are there? What are the organs which are present there? So in the right hypochondrium, it's mainly the liver. Okay, it's mainly the liver as well as some part of the hepatic flexure of the transverse column. Hepatic flexure of the transverse column. In the epigastrium, here pancreas will come here in the retroperitoneum. Okay, so the pancreas will come here in the retroperitoneum. So if there is some palpable masses are there, you can palpate in the retroperitoneum. So pancreatic masses also may be palpable in the epigastrium. Okay, especially pseudocyst or some malignancy of the system. Okay, and if there is any head of pancreas malignancy, it will be usually in the right hypochondrium or in the right lumbar area. Okay, epigastrium, it should the mass should be arising from the body of the pancreas. Most of the pseudocyst will be an epigastric mass, that is epigastric mass. Most of the pancreatic this thing will be epigastric mass. Okay. So in umbilicus, what are the things which can cause swelling? That is the most of the small intestines. Okay, anything arising from the small intestines may cause swelling in the umbilical, as well as there is a mesentery here. Okay, there is a mesentery here. Okay, the mesentery, the root of the mesentery will be here. Okay, mesentery is a large structure it's an mesentery is what connects the small intestine to the abdomen. That is the posterior abdominal wall. So obviously this is the mesentery here. So some cyst is arising from the mesentery, or some lymphatic cysts are there from the mesentery. All those things will be in the umbilical, central umbilical area. Okay, and then the other thing is the aorta, which is here. So umbilical aortic aneurysms may be there. Para-aortic lymph nodes may be there. Okay, all those things will cause swelling, which we will discuss in the next slide also. Okay, but generally we can repeat the same thing again so that you can understand it. Okay, so generally you understand. Okay, then here is the appendix. This is the main important thing. One of the for you in your exams, if they rarely keep abdominal cases, but if they keep abdominal cases, right iliac fossa mass and right iliac fossa symptoms will be the first thing which they keep. And if they want to still keep more cases, they may keep cases of epigastric mass. Epigastric mass usually a pseudocyst. Okay, mainly because you can't keep any acute abdominal cases, so those things can be kept. Or sometimes they may keep a cyst arising from the mesentery. That is rarely, because anyway it's a rare disease. Okay, mesenteric cysts are not so common. So if we get any case, we will keep. But the two cases which are commonly kept is a pseudocyst, epigastric masses, especially pseudocyst, and next one is the right iliac fossa masses. Right iliac fossa masses. Okay, right iliac fossa mass and symptoms. Okay, which we will discuss. So again, this is the transpyloric line. Okay, this is the transpyloric line, mainly because it passes through the pylorus. Here it is not shown, but it passes through the pylorus like this. Okay, and you are going to draw it where both sides 9th rib, costal margin, costochondral margin of the 9th rib. There, both sides, if you mark and a line is passed through that, it is called transpyloric line, and it will go through the pylorus. That is why it is called transpyloric. And the transtubercular line. Okay, the tubercle, the highest point in the pelvis. Okay, this is the iliac bone. The highest point in the iliac bone. Okay, that is the tubercle. Okay, so the tubercle there, the transtubercular you pass a line. Okay, that is transtubercular line. Okay, but usually the highest point of the iliac crest is difficult to palpate. So what we do, we palpate the anterior superior iliac force. This thing, anterior superior. Uh, anterior superior iliac this thing. Then we go little 4 centimeters behind that to find the highest point of the iliac crest, that is the transtubercular point. Okay, this is anterior superior iliac spine. Okay, ASIS. Okay, that is the point which you can easily palpate. ASIS you can easily palpate. It is again one of the one of the markings for your inguinal ligament also. Okay, the inguinal ligament originates from there. So ASIS is easy to palpate. Okay, anterior superior iliac spine. There 4 centimeters behind that, over in the iliac bone, that is the highest point of the point where you can mark the line, that is the transtubercular line. Okay, this is the ninth rib. Okay, ninth rib, and that is the transtubercular line. Those two, and here it is the mid clavicular line. Both sides mid clavicular line you are palpating. Okay, and that uh, that line goes two vertical lines. So those are the 4 lines which divide, 2 lines horizontally and 2 lines perpendicularly. Okay, 2 lines perpendicularly and 2 lines horizontally, and this part will be the mid inguinal point. Okay, mid inguinal point. Okay, so it will be mid inguinal point. Okay, so I take the mid clavicular point, the mid inguinal point, and you draw a vertical line, that is the 2 vertical lines. Okay, so 4 centimeters above the anterior superior iliac spine, that is the transtubercular line. Okay, ninth rib costochondral junction. You pass a line through that. It is transpyloric line, and the vertical line is from the mid clavicular point and the mid inguinal point. Okay, both you connect. It will be the 2 vertical lines. Okay, that's how you split into 9 quadrants. Okay. So, what are the organs which we already discussed? So, if you're palpating some mass, it is usually according to the quadrants, different masses can be palpated. So, what are the organs which are there in the right hypochondrium? Right hypochondrium, what are the masses which you can see? Right hypochondrium, you can see the liver as well as the gallbladder here. Okay, here the gallbladder will be there. So, in the right hypochondrium, you can see liver as well as. Okay. So you can see the liver as well as the gallbladder. This is the gallbladder here. Okay. So you may find it somewhere. It may be in the right hypochondrium as well as somewhat maybe in the right lumbar also. Okay. So the next thing which you can see in the epigastrium, stomach, left lobe of liver, pancreas, lymph nodes, aorta. Okay, which we already discussed all those things in the previous slides, but still we will see. Okay, so the left lobe of the liver. Okay, left lobe of the liver. The stomach is there in the epigastrium. The pylorus, which you can see here. Okay, and there the aorta will be here. The aorta will be centrally running like that, and the para-aortic lymph nodes. The para-aortic lymph nodes will be near the lymph nodes. So the testis, if any testicular malignancy is there, it will be going to the para-aortic lymph nodes, mainly because embryologically testis arises over near the lumbar area, and then it descends into the scrotum. Okay, so that's the reason why the blood supply as well as the lymphatic supply will be very close to the lumbar area. Okay, in the that is in the lumbar, that is in the aorta. From the aorta it arises, but very near to the kidneys, that is the lumbar area. Okay, and that's the reason why those arteries will be here. Okay, and the renal artery may come here, and from the anterior part, from laterally renal arteries will come. Anteriorly, the gonadal vessels, that is testicular vessels, arises, and near those testicular vessels, the lymph nodes will be there. That is para-aortic lymph nodes. Okay, so the para-aortic lymph nodes may be analyzed. The other thing which can be there in the epigastrium, this is the epigastrium. So the left lobe of the liver, the stomach may be there, and the para-aortic lymph nodes may be there. Okay, in this part, the para-aortic lymph node. Next, we will go to the left hypochondria. Left hypochondria mainly is the spleen, the tail of the pancreas, as well as the stomach. Okay. So this is the spleen. Okay. The stomach, some part of stomach will be there. Okay, and the pancreas, as already seen, it will come like this. Okay. This is the spleen. So this is the duodenum. So the pancreas will come like this. It will go to the oblique structure, which will be in the retroperitoneum. From the duodenal groove, okay, the duodenal groove, it will go into the hilum of the pancreas. The tail will go to the hilum of the, hilum of the spleen, okay, the hilum of the spleen. So it will pass like that. That is the pancreas there, okay. It's an oblique structure. So if it is arising from the body, the mass, which may be seen in the epigastrium, that is the pancreatic cyst, okay. And in the left hypochondria, spleen is there, and the tail of pancreas is there. Tail of pancreas, which you can see there. This is the tail of pancreas is there. Okay. And we discuss the stomach. Okay. The right lumbar is the kidney. Here you will see the kidney. Okay. Sorry. This is the pancreas. You will see the kidney somewhere here. Okay. Posteriorly, kidney will be there. So the kidney there, that is also a retroperitoneal organ, okay, because these organs are all in the intra-abdominal, which that is what you see. But some of the retroperitoneal organs also present as abdomen masses, okay. So this is the retroperitoneal organs, the kidney as well as the pancreas. So pathologies in the kidney as well as in pancreas also may present as abdomen masses, okay. So these two are the other things which you have to remember. That is the right lumbar, there may be right kidney, and left lumbar, there may be left kidney. Okay, that is over. Okay, the left also same thing, descending colon as well as the you can see this. So you can see this is the ascending colon and this is the descending colon. This is the splenic flexure, this is the hepatic flexure. So any pathology there will also be seen in near to the spleen as well as in the liver. The other pathologies, the descending colon as well as ascending colon, will present as in the lumbar area or in the iliac area. Okay. So in the right iliac fossa, this is very important. Okay, right iliac fossa masses are very important for you. So what are the different type of organs which are there in the right iliac fossa? Appendix is there, cecum is there. Okay, iliac vessels are there, okay, and right ovary as well as iliac lymph nodes will be there. But these three are most important. Okay, appendix, cecum, as well as the right ovaries. These are the important things which you have to remember. Some of the organs from which the swellings can occur. Okay. And left iliac fossa will be sigmoid colon as well as the left ovaries. Okay. So in palpation, always look at the tenderness, that is the pain. Okay, when the patient says he has pain, it is called in symptoms. It becomes a symptom. When you elicit the pain, then it becomes a sign, and that is called tenderness. Okay, tenderness is a sign. When you palpate, if the patient feels pain, that is called tenderness, and that is a sign. Okay. Rigidity and rebound tenderness, all these things are seen in emergency patients, emergency cases, peritonitis as well as peritonitis and abdomen obstructions. So usually you will not be getting in those things in the exams, but they will ask in your viva. Okay, what is rebound tenderness and what is rigidity? Okay, when there is severe inflammation of the peritoneum, abdomen wall peritoneum, the abdomen wall muscles become contracted, rigid. Okay, when you palpate, it will be like palpating a board. That is called rigidity. Okay, usually seen in severe peritonitis. Okay, late stage of peritonitis, you will see rigidity. Okay, and involuntary and guarding. Okay, involuntary and voluntary guarding. That is, the abdomen muscles again becomes taut. When you start to palpate, the abdomen muscles become taut mainly because of the pain, severe tenderness. Okay, that is also mainly because of peritonitis. But involuntary is a normal phenomenon. The patient may have pain or the patient may be apprehensive. That is, so you always ask the patient to relax as well as bend his knee so that the abdominal muscles are relaxed. Okay. So these are some of the masses which are usually seen. Okay, we will discuss, and we will also discuss how the clinically it might present. Okay, so in the right hypochondrium, that is the first thing. First is the right hypochondrium. What you will see, liver masses. Okay, liver masses are seen, and next is the gallbladder swelling. If the gallbladder is enlarged, that is called gallbladder mucosis. Okay, so the liver masses, the most common benign mass will be a, in India, hydatid cyst is also common. Okay, in Western areas, Western world, hydatid cyst may not be so common there. Hydatid cyst in a patient who is usually exposed to farm animals, you may see hydatid cyst. Okay. So in India, hydatid cyst is common. Most common benign disease of the liver will be an hemangioma, which is not usually palpable. Adenomas may be there; those are also benign. But if you palpate something in the liver, if there is a palpable mass, always evaluate for it may be a malignancy. Okay, so metastatic liver disease is one of the primary tumors which occurs. Okay, metastasis to the liver is more common than primary hepatocellular carcinoma. Okay. So metastasis liver disease may occur. So it may present as a swelling in the right hypochondrium. Okay, the metastasis may be from the breast, pancreas, stomach, colon, okay, lung as well as melanomas. And gallbladder swellings, one thing benign, it may be a mucocele. Okay, the other thing may be because of an obstruction of the ampulla of water, that is near the second part of the duodenum. If there is any obstruction there, periampullary malignancy is there, or head of pancreas malignancy is there, which is obstructing the CBD, then also the gallbladder may be enlarged. Okay, that is called Coasius law. Okay, the patient, mainly if the gallbladder is enlarged, it is not because of CBD stone. It is because if the patient has a stone there, if the patient has chronic stones, the gallbladder will always be involuted. It will be fibrotic and involuted. So the CBD stone will not cause palpable gallbladder. Usually some external obstruction into the CBD, like an malignancy or an ampulla of water obstruction, the periampullary malignancy, all those things will cause obstruction. That is called Coasius law. Palpable gallbladder most probably indicates malignancy at the periampullary areas or the head of pancreas. It does not indicate CBD stone. Okay, that is the Coasius law, which we will see in the next slides. Okay, so palpable gallbladder, always you have to suspect about periampullary carcinomas or head of pancreas carcinomas. Okay, the other benign condition where the gallbladder is palpable is a gallbladder mucosis. So what are the characteristic features of a palpable gallbladder? We will see from liver also. So what will be the clinical findings? Clinically, usually the patient will come with vague symptoms. All the upper GI symptoms, all the upper GI malignancies will present with severe anorexia. Okay, the patient will have severe loss of weight and loss of appetite, because most of the malignancies of the upper GI are aggressive tumors. So they will have cancer cachexia. So there will be loss of weight and loss of appetite in those patients. So similarly here also there will be vague unwellness. Okay, because it's a metastatic liver disease, the malignancy has spread too much. The patient will be unwell. The patient will have loss of weight, loss of appetite. All those things will be there, and the symptoms of the primary tumor will be there. Okay, HCC, that is hepatocellular carcinoma, the primary carcinoma of the liver. There the patient may present with liver failure like features. Okay, for example, jaundice may be there. Okay, and bleeding may be there, mainly because of fluctuation in the INR. Okay. The other, so that is about the symptoms of a liver mass. Now, what is the clinical examination? When you are palpating the mass, what are the clinical examination findings in the liver mass? It will be, it moves with respiration. Okay, more if in any abdominal masses which are there in the upper part of the abdomen. Okay, upper abdominal masses, always you have to look for if it moves with respiration. What is the reason why it moves with respiration? Any structure which is attached to the diaphragm. The diaphragm is the structure there. So any structure which is attached to the diaphragm moves with respiration, because diaphragm moves with respiration, and any structure is directly or indirectly attached to the diaphragm moves with respiration. What are the some of the organs? That is the liver, which is attached to the diaphragm there. Sorry, the diaphragm will be like this. Okay, this is the histogram. That is the core. So this will be the diaphragm above. This is the liver. You see, then we will here it will be spleen will be there. Okay. I'm not very good at drawing anyway. So we will just draw this thing and the diaphragm here. Okay. So the liver will be here, spleen will be here. Okay, and the stomach. Okay, and the colon. Colon. Okay. All these structures are directly or indirectly attached to the diaphragm. Okay, so liver, spleen, stomach, all those things are directly or indirectly attached to the diaphragm. Okay, so this is the hysterectomy and this is the posterior margin. Liver, spleen, stomach, and the transverse column because it is attached to the spleen here. Okay, and it is attached to the liver here, so it will be indirectly attached to the diaphragm. So the hepatic flexure and the splenic flexure, stomach, some part of the stomach, it is not, stomach is not freely mobile. Liver, spleen, okay, is very freely mobile. So all of these structures moves with respiration, mainly because they are attached directly or indirectly to the diaphragm. Okay. So when diaphragm moves with respiration, it also moves. Similarly, here you can see that it moves with respiration. Okay, so liver moves with respiration. Okay, and what are the characteristic features of the gallbladder? Gallbladder swelling, it is globular. Okay, but the gallbladder swelling may be a malignancy also, which is rare. Gallbladder malignancies are rare, but in North India it is more commoner than in the South India. North India, palpable gallbladder, always they go for an MRI because gallbladder malignancies are very common in North India. Okay, so if it is globular and if it is not irregular, it means that it may be a mucosal. Otherwise, if it's irregular, very hard, then you can suspect gallbladder malignancy also. Okay, so it will also move with respiration, and a patient, if it's a mucosal, the patient will have previous history of cholecystitis. Previous history of cholecystitis may be there, and previous history of stone in the gallbladder may be there. Okay, so that's about the right hypochondrial masses. Next, we'll come to the epigastrium. Epigastrium, what are some of the masses which you see? The carcinoma of the stomach, one, pancreas, okay, and the pre-aortic and the para-aortic lymph nodes. Okay, so those are the structures which we saw anyway, isn't it? So those are the structures which we saw there. So we will see carcinoma of stomach. Okay, carcinoma of stomach usually presents with the patient will have a chronic dyspepsia. Okay, the patient will have chronic dyspepsia, anorexia, and loss of weight and loss of appetite will be there. That is anorexia, and loss of weight also will be there. Okay, and the patient will have chronic dyspepsia. Okay, those are some of the symptoms of stomach malignancies, which is as we can see that it is very non-specific. Okay, the patient may present with hematemesis also. Okay, the patient vomits of blood, mainly because if there is an ulcer which is bleeding, then also that can be there. Okay, but if there is a palpable mass from the stomach, it usually indicates it's a late stage malignancy. Okay, late stage malignancy. The mass will be only palpable if it invades into the serosa. If it invades into the serosa, then only it will be palpable. So invasion into the serosa is T4. Okay, T4. So it becomes stage 4. Okay, so there you can't operate. The patient will not be fit for surgery. So any mass which you are palpating clinically, you are able to palpate some mass from the abdomen, some mass from the in the stomach. Usually it indicates that the patient has late stage stomach cancer. Okay, that will be a late stage stomach cancer. So anyway, if you are palpating, most of the time it will be late stage cancers, which and then malignancies of the pancreas. Okay, pancreatic malignancy, tail of pancreas also. Tail of pancreas will be in the lumbar mass. Okay, and the head of pancreas will be in the right hypochondrial area. Okay, right hypochondrial masses. This will be there, and if there is any malignancy from the body of the pancreas, you can feel it in the epigastrium. Body of the pancreas, you may feel the mass in the epigastrium. There also anorexia, loss of weight, loss of appetite, and anorexia. This is very common in all the upper GI symptoms. Upper GI malignancies, as I already told, are aggressive tumors. Okay. So and like all malignancy, it will be hard. Okay, it will be hard to palpate, hard and irregular to palpate. Okay, hard and irregular. This is very important for all malignancies. Okay, all malignancies will be hard to palpate. It will be hard. Okay, so if it's a hard mass which are palpating near the stomach, usually it is a malignancy, stomach malignancy. Here also hard fixed mass will be there, pancreatic. Okay, even normal benign masses of the pancreas is not going to move, so fixity is not very helpful there. Okay, because even the pancreas usually does not move on respiration. It's a retroperitoneal structure, it is nowhere related to the diaphragm, so obviously it will not move with respiration. Okay, but the hard is important. The hard in consistency is very important. It indicates that it's a malignancy. Okay, and we already saw that is the para-aortic lymph nodes. Para-aortic lymph nodes, a lot of abdominal organs will drain into the para-aortic lymph nodes. So having para-aortic lymph node enlargement does not tell you where the malignancy is coming from, but sometimes para-aortic lymph nodes may come from the testicular tumors also. Okay, testicular tumors, always remember, seminomas and non-seminomatous tumors can present with para-aortic lymph node enlargement. Okay, so the other areas where para-aortic lymph nodes will be there is the lymphomas. Okay, lymphomas as well as primary tumors elsewhere, multiple regions where it can occur. One of the things which you have to always remember, because you will get a scrotal case. Okay, you may get a scrotal case, and hydrocele may be there, or a testicular swelling will be there. There the examiner will ask you. Okay, there the examiner will ask you, did you examine the abdomen? Why is he asking you that? Mainly because if there is a testicular malignancy, there may be para-aortic lymph nodes. So that point you have to remember. They are not going to be keeping any pancreatic malignancy for you. Okay, hepatomegaly can be kept, and if there is any gallbladder which can be palpable, they will keep. Okay, gallbladder palpability they will keep. What are the characteristics of gallbladder swelling? It will be globular, it will move with respiration, mainly because it's in close proximity to the liver, it's attached to the liver, so it also moves with respiration. Okay, so it will be a globular swelling. Okay, and next thing is the left hypochondrium. Left hypochondrium is the space for the right hypochondrium is the space for the liver. The left hypochondrium is the space for the spleen. Okay, everything associated with the spleen. Okay, and the tail of pancreas will be there, as well as the spleen. Spleen will be there. There are multiple reasons for splenomegaly. Splenomegaly, there is in care. This case will be kept for your medicine. Okay, in medicine examination, they will keep splenomegaly. Surgery usually will not keep splenomegaly. Okay. So the spleen also moves with respiration, and you can't get above it, mainly because it goes into the it's underlying into the costal margin. It passes under the costal margin, so you may not get above the swelling. Okay, spleen. So malarial exposure, this is called tropical splenomegaly. Okay, that is called tropical splenomegaly. Hemolytic anemia, alcohol abuse. Alcohol abuse will cause portal hypertension. Okay, all conditions where there is a portal hypertension, the patient will have splenomegaly. So the patient alcohol abuse, the patient will have cirrhotic liver, which will lead to portal hypertension, and the portal hypertension will lead to splenomegaly. Okay, as I told, most of these conditions are medical conditions, and which you will be they may keep a case of splenomegaly for you in your medicine exams. Okay, this is also next thing which is very important. Rarely they may keep a case of liver. Okay, sorry, kidney, which is palpable. Kidney palpability is difficult to appreciate it unless and until the liver is the kidney is grossly enlarged. Okay, it is usually it is grossly enlarged in hydronephrosis, but here the patient will have pain. Okay, in hydronephrosis the patient will have pain, but in polycystic kidney, the patient may not have pain. There may be multiple cysts in the kidney there. So it is very rare that you will be given a case of hydronephrosis, mainly because there will be obstruction into the ureter, and the patient will be in pain. So you may not get a case of hydronephrosis. That is, there is an obstruction in the ureter. Because of that, there is accumulation of the urine near the kidney, that is hydronephrosis. Okay, it's an obstructive symptom. But polycystic kidney, with a multiple cyst in the kidney, it is the polycystic kidney again is a short note for you. Okay, there may be autosomal dominant and autosomal recessive polycystic kidneys. Okay, so you have to know all those things. So if there is any polycystic kidney, then it is easier to palpate. Okay, and the other lumbar thing is the ascending colon. Okay, ascending colon malignancies in the left side also. These things is very symmetric in the right and left lumbar area. Okay, hydronephrosis, polycystic kidneys, as well as the ascending colon. If it's an abdominal swelling, okay, which is freely mobile, it is usually a colon, ascending colon malignancy. If it's a retroperitoneal swelling, which is palatability is you ask the patient to lie down supine. Okay, so this is the abdomen of the patient. Patient is like this. Okay, you place a hand here and then one more here. Okay, and you push. This is the kidney mass. Okay, then you push from here. You push. You can feel the kidney mass comes up and it strikes your hand. Okay, this is the kidney mass. That is called palatability. Okay, this is called palatability. Okay, so this is the both hands here. So these are the hands. Okay, so if you push that, it will move. That is called palatability. Usually, it's a very characteristic sign of kidney masses. Okay, so palatable masses are usually seen in polycystic kidneys. In even hydronephrosis, they mean that palatability is very characteristic of a kidney mass. Okay, mainly because the kidney will be lying in the retroperitoneum here, so you can easily push it up. If it's a large mass, you can push it above, and it will come and strike your hand, which is above. That is called palatability. Okay. It may be mobile or it may be fixed. Okay, if it is an ascending colon malignancy, it may be usually be fixed. The ascending colon does not have a mesentery, so it is the malignancy. If it arises from that, will be fixed. Okay. Next is the umbilical area. Okay, all the 9 quadrants we will discuss. Okay, 9 quadrants. So next is the umbilical. So what are some of the swellings you can see? That is the omental or metastatic omental tumors or mesenteric cyst. Okay, which we already discussed. Okay, mesenteric cyst. Then we will see transverse colon. Okay, and abdomen aortas and metastatic lymph nodes, which can be also there. And in the umbilical, the duodenum and pylorus also comes there. Okay, and as we all discussed, even the pancreatic pseudocyst also may come. Okay, pancreatic pseudocyst also is very important. Okay, and the left lumbar is similar to right lumbar, which we already discussed there. So in mesenteric metastatic omental tumors, omentum is a large peritoneal fold which is seen, which covers all over the abdomen. So if any abdomen tumors or the omental tumors are there, which you can palpate in the umbilical area. So this will be the stomach, the umbilical area. So the stomach will be here. So the mesentery will come from, omentum will come from the larger. Okay, so it's just an whole thing. This will be covered. This whole thing is the omentum. Okay, omentum. So any of our omental deposits are there, you may feel near the umbilicus. Okay. Then the transverse colon, it's a very mobile. Okay, the transverse colon has a large mesentery. Transverse colon, which you see here, the transverse colon will be it will be attached to the stomach here. So the transverse colon has a large mesentery. Okay, so it will be attached like that. Okay, it has a large mesentery. So it will be freely mobile. The transverse colon will be freely mobile. Okay, transverse colon will be freely mobile. So any tumor of the transverse colon will be freely mobile, as well as omental tumors also will be freely mobile, because it is a large area. We can freely the omental tumors also will be freely mobile, and transverse colon also will be freely mobile. Horizontally as well as vertically, it will be freely mobile. Those are the characteristic features. Okay. And aorta will come here, as we all discussed. Okay, aorta will come there. Okay, so midline, if there is any abdominal, the aortic aneurysms there, you can feel. Okay, so that's about the umbilical area. Umbilical area, metastatic omental tumors may be there, and colon as well as metastatic lymph nodes may be there. Okay, next we will go to the the important other important things, the right iliac fossa as well as the left iliac fossa. Okay, the right iliac fossa and the left iliac fossa. Again, the key team will be palatable that we already discussed. So right iliac fossa masses, what are the structures which we saw? It is appendix, cecum, and the ovary which is there. So obviously the appendicular masses, it can be because of appendicular mass as well as the cecal masses, all the differential diagnosis. Okay, cecal and appendicular, the appendicular mass is mainly because of chronic appendicitis. Okay, chronic appendicitis will lead to appendicular mass, that I hope you know. Okay, if the patient has a past history of acute appendicitis and if it is not treated, it will progress into appendicular mass. Okay, that is the body's way of containing the infection. The body's way of containing the infection. It consists of the mesenteric omentum, appendix, as well as the surrounding bowel. Okay, so it forms a mass there so that the infection is just contained in that. Okay, so that is called appendicular mass. Next thing, which right iliac fossa masses may be because of tuberculosis. Okay, iliac as well as the cecal part are prone for tuberculosis. So in an abdominal tuberculosis, then it may present as a right iliac fossa mass. So tuberculosis, appendicular mass, as well as cecal carcinomas are more common, which presents as right iliac fossa masses, which is very important. Okay, so there may be mobile or fixed. If appendicular mass is there, always ask for previous history of appendicitis. Okay, it's a right-sided malignancies, right-sided colonic malignancies usually will present with anemia. Okay, will present with anemia. Left-sided colonic malignancy will present with alteration in the bowel habits, most commonly constipation. Okay, so the anemia part is very important if the cecal malignancy is there. Next is the hypochondrium, or suprapubic area we call. Okay, suprapubic area or the pelvic area. Okay, the suprapubic area, that is called the hypogastrium. Hypogastrium. So what are the structures there in an abdomen? So we have the 4 lines there, isn't it? So here uterus may be there. Okay, ovaries will come in the uh, this one, hypochondriac areas, iliac areas. Okay, uterus may be there, or the bladder may be there. Okay, the bladder may be there, and here the prostate comes. Okay, prostate comes in the pelvic area. Okay, so bladder may be there, uterus may be there. Okay, and then also the sigmoid colon also comes. Okay, sigmoid colon and the rectum also comes in that area. Okay, so those are the structures, some of the structures which are there in the pelvic area. So one thing is the bladder, next thing is the uterus, which we already saw, isn't it? And ovarian cyst and ovarian tumors may also see in the iliac areas as well as in the hypochondriac areas in this area. So all the pelvic organs. Okay, pelvic organs. Okay, and sometimes even the rectal, the sigmoid colon malignancy also may be palpable in that area. Okay, sigmoid colon malignancy may also be palpable in that area. So fibroids, the patient will present with irregular cycles. Difficulty if the patient has some bladder tumors or bladder malignancy is there, if the bladder mass is there, then difficulty in maturation will be there. Okay. So left iliac, the sigmoid comes from the left iliac fossa and descends into in the middle. Okay, it forms a rectum in the middle. So the sigmoid colon malignancies will present in left iliac fossa. Okay. So here also the change in bowel habits. This is the most common thing. Okay, constipation and change in bowel habits. As I already told, left-sided colonic malignancies usually presents with constipation. Okay. So those are all the different differential diagnosis of all the masses which are seen in each of the quadrants. Okay, these are all intra-abdominal masses. The other masses which can be seen are arising from the abdomen wall also. Okay, abdomen wall, for example, lipoma, sebaceous cyst, like common things which arises in everywhere in every part of the body. Here also it can arise. Okay, the sebaceous cyst may arise from the skin. Okay, and the lipomas may be in the subcutaneous areas. And in the fascia of the abdomen, sometimes there may be desmoid tumors. Okay, desmoid tumors may be there. Okay, that is also abdominal wall tumors. Then there is a muscle in the abdominal wall. So what are the layers of abdominal wall? skin is there, then subcutaneous tissue is there. So subcutaneous tissue, lipomas may occur. The next layer is the fascia. From fascia, desmoid tumors may occur. The next layer is the muscle. Okay, from muscle, what all can occur? There may be hematomas in the muscle, or there may be even sarcomas in the muscle. Okay, some sarcomas also may be there in the arising from the muscle. Okay, it may be malignant or it may be benign, like anywhere in the body, wherever the muscle is there, may be benign or malignant. Okay, so these are all the masses, differential diagnosis. Okay, so which we have discussed, and then we had to do for palpation. Okay, what I wanted to show was this. Okay, this is the fullness of flanks. Okay, the flanks are full. Okay, the flanks are full. That is what is called as this is the flank, isn't it? Normally it will be like this. Okay, normally it will be like this. So it is full here. That is usually seen in ascites, patients with ascites. So I just wanted to show you this picture. Shifting dullness, all those things are seen in ascitic patients, which they will discuss in your medicine classes. Okay, I just wanted to show that. If there is a diffuse enlargement of the diffuse abdomen distension is there, if the flanks are full, you suspect ascites. Okay, so those are some of the differential diagnosis of abdomen masses and how they will present. Okay. Okay. So thank you. Okay. Uh, that's all for today's class.